Okay, so a very good morning to all. So today we are going to discuss certain conceptual MCQs in dermatology. So with that, I would like you to know that Unacademy is coming up with the NEET PG 2022 mock test, all India mock test, which is going to be held on February 26th. Please remember this date. It is February 26th at 9 a.m. Okay, it is the final chance before the final exam, okay, where you can compete and you can test your preparation. So please do enroll for this test. When you do enroll, please use the code mentor. MENTOR is the code which you need to use so as to get access to this test. To tell you about the NEET PG 2022 All India mock test, it is made in a pattern and the questions are predictive of the main exam. There will be analytics that will showcase your valuable insights and solutions and options for conceptual and clinical learning will be provided. Okay, so they will be provided to you in the PDF format, as well as there will be video solutions which will be given by the India's top educators. So please do enroll in this particular examination, and when you do so, please use the code mentor. MENTOR is the code that you need to use to get access to these lectures, this examination. Also, to tell you about crack the NEET PG with combat. Now this combat is going to be held on February 19 at 6 p.m. So this particular combat is covering the subjects of orthopedics, OBGY, surgery and pediatrics. So you will experience the thrill of a live combat test. You will practice and get real-time All India ranking among the thousands of learners who will be on the platform. The questions are created by the top educators. Detailed video solutions will be provided and you stand a chance to win up to 100% scholarship. And top rankers can win exciting rewards. So please do enroll into this combat, and when you do, use the code mentor. Okay, MENTOR is the code that you need to use. 10 lucky participants will get amazing gift vouchers. Okay, so please do use this particular opportunity. Unlock 20. You just use this code MENTOR. When you use this code, and you can unlock 20% off on all the Unacademy subscription, but this is valid only till Wednesday, Feb 16th. Okay, that is today. So today, for this particular day, there is an offer where you just enter the code mentor and you can get access to 20% off on all the Unacademy subscriptions. To tell you about the subscription, we have the plus subscription of Unacademy, where you have access to both the live and the recorded classes. You learn from India's top educators for the medical exams. You compete in live tests and quizzes, and you study on a device of your choice. Whether it's a phone or a laptop, you will be able to study on the device, and you have an access to a question bank which has more than 25,000 questions with highly effective explanations. There is also another subscription available which is called as the iconic subscription. Okay, so this iconic subscription, it's a combo of both Unacademy and Prep Ladder. So for all the advantages of Unacademy, you have well structured live batches, recorded classes. Okay, you have full syllabus covered, you have a question bank, and you have live tests and quizzes. While through Prep Ladder, essentially in addition to all that is offered by Unacademy, you will have clinical and integrated essentials, video lectures from the Dream Team, question bank, rapid revision and snapshots, and treasures in 2021 Dream Notes. These are the toppers of FMGE examination 2021. They are all students of Unacademy and they have done very, very well. Also, to tell you about the upcoming series, the PYQ series, please remember that uh, there is going to be regular PYQ series of various subjects which will be at different dates. Okay. Also, there are special classes available. They are completely free and they are interactive live classes where you have polls for the learners. You can also raise a hand. You can talk to the educator live. Okay, you can get your doubts solved in real time. You never miss a class because you are always notified about the classes. And lecture notes are available where you can access them anytime and anywhere. To tell you about the upcoming batches, we have the NEET PG All in Educator Revision batch. So all the 90 educators, 40 plus educators which are there on Unacademy will be there in this batch. This batch is specifically curated for the NEET PG students who are appearing for the 2022 examinations. The duration of this batch is 3 months. So it's started off today, that is 16th of Feb, and it will go on up to 10th of May. There are 8 grand tests and there are 140 hours of revision, 4 hours per day, and 19 top quality subject wise tests. Okay, so it has a well defined structure where you can attend the revision classes, you can self study, then give a grand test, and then there can be a solution discussion. Okay, to tell you about the ultra fast revision test, the dermatology part of the ultra fast revision test starts on 19th of February. Okay, 19th February, that is this Saturday, Sunday, we'll be doing an ultra fast revision of dermatology on Academy. Okay, so it's a well structured batch in which all the 19 subjects will be covered. Then you have a NEET PG 2022 previous year questions batch, which is going to last for 15 days, and 16th February is the big date that it begins, that is today. So basically, all the advantages again will be covered here as well. Then you have an image-based question bank batch, which is again for 15 days, where all the 19 subjects, all image-based questions will be covered. Then for the students who are appearing for the FMGE examinations in December 2022, there is a comprehensive batch which is for 9 months. Starts from today, will go on up to 22nd of October. Then there is a Focus FMGE comprehensive batch which will be for 4 months. 16 February to May 2022 is the duration of this batch. And for all this, what you need to do is to either opt for the Unacademy subscription or you can opt for the Iconic subscription. So if you're going to opt for the Unacademy subscription for a period of say around 12 months, it would cost you around for a period of 12 months, the Unacademy subscription would cost you, for the Iconic subscription, it would have cost you 48,500, but you can use this code mentor today. Only for today, if you use this code mentor, you get a 20% off, and that would help you to get a discounted rate of 38,400. Okay, so please do make use of this particular offer. So with that, let's begin with a few MCQs today. Okay, so let's go to the first MCQ. Okay, now you have a 30-year-old man who has this lesion on his body. Okay, now it has been present for the past 2 years. What is the most appropriate morphological term to describe this lesion? Okay, so the most appropriate morphological term that you would describe this lesion, will you call it a cyst, nodule, papule, or a plaque? Okay, so the correct answer here, if you look at the lesions here, if you look at the lesions here, yeah, they are minimally elevated lesions, right? So among the minimally elevated lesions, you can have a papule, you can have a plaque. A nodule is where the vertical dimension is more as compared to the horizontal dimension, right? So it cannot be a nodule. Okay, so basically we can say that they look like papules. Okay, so the correct answer here is a papule, where you can see that it's a circumscribed palpable elevation which is less than 1 centimeters in diameter. The only distinction between a papule and a nodule is the size. Okay, and Nodule is basically a solid palpable lesion which is present in the dermis or the subcutis, which can be observed as an elevation or it can be palpated. It is more than 0.5 centimeters in diameter. Okay, it consists of fluid or extracellular material, amyloid or inflammatory or neoplastic cells. So nodules, they tend to have a deeper component. Okay, and they are better palpated than they are seen. A plaque is an elevated circumscribed lesion which is greater than 1 centimeter in diameter. So the difference between a papule and a plaque is the size. So a papule is going to be less than 1 centimeter while a plaque is going to be more than 1 centimeter. And the other option was a cyst. So cyst is any closed cavity or a sac which can be normal or abnormal with an epithelial, endothelial or a membranous lining and containing fluid or semi-solid material. Okay, so that is a cyst. So papule, it's a circumscribed elevated lesion which is less than 1 centimeter in diameter. Nodule is better palpated than seen. Plaque is elevated circumscribed lesion which is more than 1 centimeter in diameter, and cyst is a closed cavity or a sac with an epithelial, endothelial or a membranous lining and contains fluid or semi-solid material. Okay, so that is the definition, basic definition of terms that are used in dermatology. Okay, now let's go to the next question. You have a 3-year-old boy who presents with fever, runny nose, cough and a rash on his body. Okay, now symptoms of cold started a few days ago, but his mother noticed the rash this morning. How would this eruption be described on the image? Is it a herpetiform rash? Is it a lichenoid rash? Is it a morbilliform rash, or are they melia? Now if you see the word herpetiform means herpes-like. So what is the classical manifestation of herpes? They are vesicles. Vesicles are fluid-filled lesions, right? So they are vesicles which are grouped together on an erythematous base, right? So there is nothing that signifies any vesiculation here. Hence, the answer cannot be herpetiform. Lichenoid lesions have a characteristic lichenoid violaceous hue. The current picture is showing you presence of erythema, right? So it is not lichenoid. It cannot be melia because melia do not are not, they are not going to appear in a few days. They are not related to any infection and they do not show any component of erythema. Basically they are keratin cysts which are present under the skin. Yes, Hemant, you are right, they are melia. But the answer here is not melia. The correct answer here is morbilliform. Okay, the correct answer here is morbilliform. So morbilliform, it's a generalized small erythematous macules and papules showing circular elliptical lesions which are varying in diameter from 1 to 3 millimeter. Okay, so initially they will be discrete macules and then they will be coalescent so as to form a sheet of erythema. Okay, so this is a morbilliform rash. Herpetiform, you will have grouped vesicular lesions which will be coalescing together with polycyclic margins. Lichenoid lesions will be violaceous to purple in color and they will look like lichen planus, right? So they will be polygonal lesions that resembles those in lichen planus. Melia are soft, firm, white papules which are filled with keratin. They do not have any erythematous base to it. So what is morbilliform? Morbilliform literally means measles-like. Okay, so that means it means maculopapular. So morbilliform or measles-like eruptions are the most common cutaneous manifestations of drug-induced eruptions in children. They are fine erythematous macules and papules which are distributed over the trunk. The rash often spreads centripetally. That means it starts off in the center and then progresses in the periphery. Lesions may coalesce to form large plaques and they are usually pruritic. So, what is the differential diagnosis of a morbilliform eruption? A morbilliform eruption can be either viral eruption or it could be a drug eruption. Now, morbilliform viral eruption can be seen in measles, rubella, scarlet fever, HHV6 eruption. They are all morbilliform eruptions, means they are called as maculopapular eruptions. Okay, they are all macules, papules, they are minimally elevated and they tend to coalesce together, right? So morbilliform viral eruptions are multiple. Then there can be drug eruptions like common antibiotics like say penicillins, sulfonamides, thiazides, sulfonylureas, non-steroidal anti-inflammatory drugs, aromatic anticonvulsants and gold. They can trigger off a morbilliform eruption. Okay. There are uncommon causes of morbilliform eruptions like severe drug hypersensitivity reaction. Hemant, Vipesh, can you tell me which drugs can cause a drug hypersensitivity syndrome? Any common drugs that you know which can cause drug hypersensitivity syndrome? Anyone? Which are the drugs that can cause a drug hypersensitivity syndrome? Okay, so how does a drug hypersensitivity syndrome differ from a regular drug reaction? One thing is that in a drug hypersensitivity syndrome, the symptoms are not going to be immediate. Okay, the symptoms are going to develop usually around 4 to 6 weeks after the inciting drug has started. Okay, second thing is that drug hypersensitivity syndrome, please remember the drugs. They are drug hypersensitivity syndrome is caused by common drugs that we use in dermatology like dapsone, which is also called as the fifth week syndrome or dapsone syndrome. Then nevirapine. Then remember even minocycline can cause a drug hypersensitivity syndrome. Anticonvulsants are very important cause of drug hypersensitivity syndrome like phenytoin, phenobarbital. They can cause, and as a part of AKT, INH can cause a drug hypersensitivity syndrome. INH, PZA, they can cause drug hypersensitivity syndromes. Okay, so remember, drug hypersensitivity syndrome is not just limited to the skin. Okay, so you will have a maculopapular rash on the skin which will then become coalescent usually around 5 weeks after starting the offending drug, and it will be associated with systemic symptoms. Okay, if you take a blood smear, you will see the presence of eosinophilia. Okay, so you will see eosinophilia. In addition, you will have lymphadenopathy. Okay, that is very important. They will have lymphadenopathy and they will have organ involvement. Okay, so organ involvement, the most common organ to be involved in drug hypersensitivity syndrome is the liver. So they can get hepatitis. It can also involve the kidney and can cause glomerulonephritis. It can involve the stomach, it can involve the lungs, right? So any organ can be involved, but the most common organ to be involved is the liver. So what do you need to remember about drug hypersensitivity syndrome is that it can be caused mainly by anticonvulsants, anti-tubercular drugs, dapsone, nevirapine, minocycline. Okay, it usually starts off between 4 to 6 weeks after the starting of the offending drug, and it manifests as DRESS, that is drug reaction, eosinophilia and systemic symptoms. Okay, so you have fever, you will have swelling of the face, you will have swelling of the extremities, there will be a rash over the body which will be extremely pruritic, and the patient will have associated lymphadenopathy. Patient will also have associated systemic symptoms. Apart from fever, patient can have organ involvement in terms of hepatitis, glomerulonephritis, right? So even drug hypersensitivity reaction can manifest as a morbilliform eruption. Then lupus erythematosus. Now you know lupus erythematosus, the systemic lupus erythematosus, it can manifest as a morbilliform rash. Okay, that is one of the non-specific manifestations of lupus erythematosus. The specific manifestations, I think all of you are aware. It is the butterfly rash. There can be erythema multiforme like lesions and toxic epidermal necrolysis like lesions, which are specific for SLE. The non-specific lesions include morbilliform rashes. Rickettsial infections. Now this is very important. Remember, when you see lesions which are a little purpuric, and when they start off in the acral areas, that is on the palms and the soles, and then they progress to the central area of the body, okay, associated with a toxic look and the patient is quite unstable, okay, you should think of rickettsia as one of your differential. Okay, so rickettsial infections rarely can manifest as a morbilliform eruption as well. Serum sickness, again, it's a type 3 hypersensitivity reaction. Following around 21 days after the starting of the offending drug, the patient develops urticarial lesions. These urticarial lesions, they look like urticaria, but they have a central kind of a pigmented hue to it. Along with it, the patient is having severe systemic symptoms in terms of fever. There can be arthralgia, there can be nausea, vomiting, myalgia, right? So that conforms to the diagnosis of serum sickness, which can happen even after vaccinations. Okay, so that can happen around 21 days after the onset of the drug or the vaccine. Then roseola vaccinatum again can manifest as a it can manifest as a morbilliform rash. This eruption is usually self-limited, may last for an average of 1 to 2 weeks. So first of all, when you are encountering this kind of a morbilliform rash, you take a very detailed history and you do a very thorough clinical examination. Okay, so in the history, you're going to ask, when did the rash appear? Where did the rash start? Was there any preceding fever? Was there any other systemic symptom? Was there any cough, cold? Is this particular rash associated with any enanthems? Is there any involvement of the oral cavity, genitalia, conjunctiva? Okay, you're also going to ask whether the rash is asymptomatic or is it itchy. Then you will do the clinical examination. You will palpate the lesions as well. You will see whether the lesions are discrete or are they confluent, are they purpuric, are they erythema multiforme like, are the lesions associated with any lymphadenopathy, whether the lesions are associated with involvement of the palms and the soles, what is the status of the oral cavity, genitalia and the eyes, right? So all these points have to be covered in your history clinical examination. Then accordingly you make up your mind whether you are dealing with a drug induced cause, or are you dealing with a viral eruption, or is it something more sinister like drug hypersensitivity reaction or lupus erythematosus or rickettsial infections, and then accordingly you order your labs. Okay, and then if it's a morbilliform viral eruption, you don't need to do too much. It's a self-limiting thing. You just give conservative treatment, symptomatic care with antihistamines and emollients, and your job is done. Okay, let's go to the next question. Spot the diagnosis given on the clinical image. Is it stasis dermatitis? Is it seborrheic dermatitis? Is it atopic dermatitis? Or is it dyshydrotic eczema? Anyone? Can anyone put up the answer on the chat box? Anyone can put up the answer on the chat box? Yes, so Vipesh says it's 4, that is dyshydrotic eczema. Very good, Vipesh, you are the correct. So basically, see, it cannot be stasis dermatitis. Where does stasis dermatitis happen? Dawood, it's not stasis dermatitis. Where does stasis dermatitis happen? Stasis dermatitis will happen at the sites of stasis. It will happen where your areas are dependent, right? So it will happen on the lower extremities, especially along the gaiter area of the foot, right? So stasis dermatitis definitely is not the answer. Seborrheic dermatitis happens on the seborrheic areas of the body. Okay, so what are the seborrheic areas? The scalp, the retroauricular area, the nasolabial fold, the nasal crease, the infralabial crease, the central chest, central back, armpits, and the groins. These are the areas where you can see seborrheic dermatitis. You don't see seborrheic dermatitis on the palms, right? And seborrheic dermatitis is characterized by the presence of yellowish greasy scales. Okay, so seborrheic dermatitis is also not the answer. Atopic dermatitis you can diagnose not as a spot diagnosis. You have to diagnose it by a set of criteria, right? So atopic dermatitis is diagnosed by the Hannifin and Raikas criteria. They have been divided as major criteria and minor criteria. Okay, so depending upon what is the age, the manifestation of atopic dermatitis will differ. So definitely this is not atopic dermatitis. This is dyshydrotic eczema. Okay, so dyshydrotic eczema usually presents as deep-seated vesicular lesions. You can see in the picture here, they are deep-seated vesicular lesions which are usually located on the lateral aspects of the fingers, and then they tend to be extremely pruritic. In fact, they look like sago grain like vesicles under the surface of the skin, and then they ooze, then they may scab. Okay, and it is an extremely pruritic, sometimes a recurring kind of a condition. Okay, so dyshydrotic eczema, please remember, it's a variant of hand eczema. It is pruritic with a wet appearance. The vesicles are arranged in groups and annular patterns with crusting over an erythematous base. The affected areas are the palms, soles, sides of the fingers and toes, and it crusts and then it heals. Okay, so this is more commonly seen in people who have an atopic diathesis. Okay, so stasis dermatitis develops like venous eczema. Okay, and it may develop suddenly or insidiously. There are erythematous, scaly, and often exudative eruptions usually seen around the ankle and the lower leg. Eczema is often accompanied by other manifestations of venous hypertension like pigmentation, stasis pigmentation. You can see varicosities on the skin. So those things can be associated. Then seborrheic dermatitis, as I told you, it's a localized inflammation and superficial flaking of the skin where you see involvement of the nasolabial fold, ear crease, eyelids, glabular area and the medial eyebrows. Scalp, torso and the folds can also be involved. There will be yellowish greasy scales and crusts. Then palmar psoriasis. Palmar psoriasis typically presents as scaly patches with a silvery micaceous scale which can be evoked on scratching. The other differential is that palmar psoriasis will have a very well defined border, and on the dorsal surface the knuckles often show a dull red thickening of the skin. Pompholyx is basically a type of eczema of the palms. Okay, and in which the edema fluid accumulates. Okay, and that forms vesicles and bullae. The condition is more common in the hot weather. Now let's go to the next question. 17-year-old man presents with a rash that has been present for around 4 weeks and is mildly itchy. A potassium hydroxide mount is negative. The image given below shows the distribution and the character of the rash. What is the most likely diagnosis? Is it lichen planus? Is it pityriasis rosea? Is it psoriasis or is it tinea? Vipesh, Hemant, Daud, anyone? Great, Vipesh, you are right. The correct answer here is pityriasis rosea. Right, now why is it pityriasis rosea? Okay, why is it pityriasis rosea? See, because they have specifically mentioned that the potassium hydroxide mount is negative. So definitely it cannot be tinea corporis. If you see the lesions, you can see that there is a large patch here. Okay, and then there are smaller patches. Okay, so this patch is nothing but the herald patch. Okay, it is the herald patch, also called as the mother patch. Okay, this patch is the one which comes first on the skin, and after a few weeks you see multiple daughter lesions. So all these are daughter lesions which are smaller. If you see the picture very carefully, you will see that it's an annular plaque with typical collarate of scale. So here you can see the collarate very well. Collarate of scales. So annular plaque with collarate of scales associated with mild itching, starting off as a herald patch, followed by the appearance of the herald patch. Within a few weeks there are multiple daughter lesions that are seen. This eruption is very classically seen in pityriasis rosea. In lichen planus you would have flat topped violaceous. Violaceous means purplish. Flat topped violaceous papules. right? So this presentation is not fitting into lichen planus obviously. Psoriasis will show you the presence of erythematous indurated plaques, okay, and they will have associated silvery micaceous scales. Okay, so silvery micaceous scales are seen with psoriasis. Okay, so definitely it cannot be psoriasis. The correct answer here is pityriasis rosea. What you need to remember about pityriasis rosea is that this condition is caused by virus HHV6 and HHV7. Okay, HHV6 and HHV7 are thought to cause pityriasis rosea. It starts as a herald patch and then the daughter patches are going to be present on the trunk in a typical Christmas tree distribution, Christmas tree pattern. Okay, so this is again a very important MCQ. Christmas tree pattern is seen in pityriasis rosea. The lesions have a typical collarate scale. Okay, so that is again a very important MCQ. You have a collarate scale. Also remember that you have a sign in pityriasis rosea which is called as the hanging curtain sign. What is the hanging curtain sign? When you stretch a lesion of pityriasis rosea, the scales are going to turn inwards. That is the hanging curtain sign that you see in pityriasis rosea. Okay, so please remember pityriasis rosea caused by HHV6 and 7. You see a herald patch, mother patch. There is a typical collarate scale. The daughter lesions, they tend to appear a few weeks after the appearance of the herald patch and they are typically distributed in the Christmas tree pattern on the trunk. Okay. So if you see lichen planus, which was one of the differentials, it had purplish violaceous flat top papules. The classical sites of lichen planus are on the folds. You see it on the wrists. You can see it on the extensor legs. You can see them on the trunk. Okay, so lower back. Okay, and scaling is usually absent. But what you see is something called as Wickham's striae. Okay, so what are these Wickham's striae? Wickham's striae are the reticulate striae which you see on the surface of a papule of classical lichen planus when you apply a oil drop and you see it via a magnifying lens. Okay, so Wickham's striae are seen on a papule of lichen planus and this Wickham's striae are seen clinically because of the histopathological appearance of wedge-shaped hypergranulosis in the histopathology of lichen planus. Okay, so the sites are usually the wrists, ankles and the lower backs. Scaling is usually absent, itching is present and the KOH mount is obviously negative. In pityriasis rosea, you will have erythematous papules and plaques, annular, and you will see pseudo crinkling in the center. The trunk is predominantly involved and there is a collarate scale. Itching may or may not be present. KOH is of course negative. In psoriasis, you see salmon pink colored erythematous plaques which are covered with silvery micaceous scales. The distribution of psoriasis is usually on the extensors. So you see it on the knees, elbows, scalp, extensor aspects. Tinea corporis presents with annular plaques with central clearing, peripheral scaling, and itching is obviously present and KOH mount is also going to be positive. Okay, so that's how you differentiate between these four options. So this is what I have already covered, so I'm not going through it again. Let's go to the next question. You have a 6-month-old child who is brought by the mother with a rash as shown in the picture. So now look at the history very carefully. 3 days ago, she took him to the emergency after the boy spiked a fever of 104 and had a seizure at home. His workup was normal and he was sent home with acetaminophen and fluids. Now this morning, so 3 days ago he had fever, spiked to 104, had seizures and all his workup was normal. So he was given just acetaminophen and fluids and he was sent home back. Now this morning he developed a rash on his trunk which his mother believes is spreading to his arms and legs. What is the most likely diagnosis? Is it a drug eruption? Is it erythema infectiosum? Is it measles or is it roseola? Look at the age of the child. Look at the typical history. 3 days fever, fourth day rash, fever gone. Okay, so the correct answer here is roseola. Okay, now please remember this very importantly. If you have lack of symptoms during the febrile phase and appearance of the eruption as soon as the fever subsides, then this history is very classically seen in roseola. Okay, so this child had fever. At that point in time, he was completely fine. He just had fever, had a febrile seizure, and then after 3 days of the fever, developed a rash, and the fever has gone. Okay, so this particular eruption is nothing but roseola or roseola infantum, also called as exanthum subitum, also called as sixth disease. Okay, so HHV6 causes roseola infantum and it is the most common exanthematic fever in children under the age of 2. So it manifests as a rosy rash on the trunk and the neck after 3 days of high fever. It may spread to the arms, face, legs. It is a self-limited disease not requiring any treatment. Clinical confusion with rubella or measles is not uncommon. Now, Vipesh mentioned the answer as a drug eruption. Why is it not a drug eruption? The fact that the child had fever prior to the appearance of a rash, it would suggest more of a viral infection. Drug eruption, most of the times they do have a very pruritic rash. Okay, and in drug eruptions, usually the palms and the soles are involved. Okay, so considering the age, considering the entire scenario of the high grade fever and following the stoppage of the high grade fever, the patient developing a rash, this goes more in favor of the diagnosis as roseola. Okay. Erythema Infectiosum is caused by parvovirus B19 and it typically presents as a slap cheek appearance. So you see redness over the both the cheeks and after that you see a reticulate kind of a rash which is seen on the trunk. Okay, so this clinical description that is given to you, it does not fit into erythema infectiosum. It's not measles because measles usually you have fever and along with the fever you develop the rash. Okay, so on the around the fourth day of the fever you start developing the rash. So the fever and the rash can coincide and you will see that the rash typically starts off around the forehead on the retroauricular area and then progresses down. Okay, so this clinical scenario fits better into roseola. Okay, now this is what erythema infectiosum looks like. This is the fifth disease or erythema infectiosum which is caused by human parvovirus B19. Okay, so this will give you a slap cheek appearance. So you can see the slap cheek appearance in this patient. This is what measles would look like. So it's a maculopapular rash which begins on the hairline and the retroauricular area and then it progresses from up to down. Okay, so there will be a kind of a cephalocaudal progression. You will see that it involves the face and the upper neck and later involves the extremities. Along with measles, along with the rash, the child will also have other symptoms like fever, cough, running nose, congested eyes. Okay, and very characteristically, there will be associated enanthem like Koplik spots. Okay, so that is in fact the first, that is kind of the first. Just 1 minute. Okay, so this is going to be the first manifestation of measles. You will have Koplik spots as uh, kind of grayish colored macules which are present opposite to the lower second molar. Okay, now look at this question. true about the following tongue lesion? Geographic tongue associated with vitamin B deficiency, reticular plaques associated with oral lichen planus, candidiasis associated with diabetes, oral hairy leukoplakia associated with Epstein-Barr virus infection. What is it? Look at the image and make a diagnosis. Can anyone tell me the answer? So Aishwarya says it's 4. Anjum says 4. Vipesh and Daud are of the opinion it's 1. Okay. So Aishwarya and Anjum, both of you are right. The correct answer here is oral hairy leukoplakia associated with Epstein-Barr virus infection. Okay, it's not a geographic tongue. Geographic tongue will look like localized atrophy of papillae, right? So that kind of a picture is not what you see here. So it's not a geographic tongue. It is not a reticulate plaque associated with oral lichen planus. Usually you see oral lichen planus on the inner aspect of the buccal mucosa. You will see it on the inner aspects of the upper and the lower lip. Okay, you may see it on the tongue, but the sides of the tongue is not very common, and you don't see these kind of corrugated appearance of lesions, right? So it is not lichen planus. It is not candidiasis. Candidiasis would present as rather a white colored plaque, not having this kind of a corrugated surface. This location on the lateral aspect of the tongue with this corrugated appearance of the lesions is something that is very classically seen in oral hairy leukoplakia. It's caused by Epstein-Barr virus. It is more common in the HIV setting. Okay. So it can be seen as an opportunistic infection with EBV and HIV/AIDS. Usually it is bilaterally present and it is corrugated. It is symptomless. So how do you manage uh, oral hairy leukoplakia? You can just leave it alone, or you can give antiretroviral agents, improve the immunity so that the body takes care of it, or you can give acyclovir or ganciclovir. Sometimes topical retinoids can also be applied. Geographic tongue would present as multiple red patches with irregular yellow-white border present on the dorsal lateral tongue. The lesions migrate and are usually asymptomatic. They are associated with cutaneous disease, reactive arthritis, generalized pustular psoriasis, and necrodermatitis continua of Halepi. Candidiasis, you will see that there will be surface debris, pain, burning, okay, and can be associated with the use of antibiotics. It can be associated with use of steroid inhalers if they are not used properly. It can also happen in patients with diabetes. Okay. Then oral lichen planus typically has a reticulate lace-like keratotic mucosal configuration. Wickham's striae and violaceous hue can be seen. It's more common on the buccal mucosa and on the gingival margins. Okay, so that's how we differentiate between these entities. All okay? Please give me a thumbs up if you have understood everything. If there are any doubts, any questions, please let me know. Vipesh, Anjum, Aishwarya, Daud, all okay? Please give me a thumbs up so that I can progress. Thank you, Aishwarya. Thank you, Vipesh. So let's go to the next question now. Now look at the image that is provided. The lesions on this infant's face are usually associated with acquired rubella, congenital rubella, syphilis, or rubeola. So Aishwarya says it's 2, that is congenital rubella. Anyone else? Daud also says it's congenital rubella. Yes, so Aishwarya and Daud, both of you are right. It is actually a blueberry muffin lesion, blueberry muffin baby, which you see as a part of congenital rubella. Okay, so congenital rubella can manifest as a blueberry muffin baby. These bluish colored papulonodular lesions that you see are actually the sites of dermal erythropoiesis. Okay, so this blueberry muffin rash is typically seen with torch infections. So congenital rubella, as a triad of congenital rubella, first you see blueberry muffin eruptions. So they are dark blue to magenta, non-blanchable, indurated, hemispheric purpuric papules. The lesions, they favor the head, neck and the trunk. The triad of congenital rubella is cataract, congenital heart defects and deafness. Okay, so cataract, congenital heart defects and deafness, these are the three things that you see in congenital rubella. Acquired rubella, in contrast, is characterized by transient erythematous rash, conjunctivitis, coryza, post-auricular. Now, this is very specific. Post-auricular and suboccipital lymphadenopathy, low-grade fever and nausea. Arthritis and arthralgia may occur in children but may affect in up to 70% of the adults, particularly women. Measles, on the other hand, would present with high fever, cough, running nose, watery red eyes. Coplic spots will appear around 2 to 3 days after the symptoms begin, and skin of the patient will start developing symptoms after 3 days of the measles infection. So usually there will be a maculopapular rash which will start off in the hairline and then it will spread downwards, and the spots may become coalescent also, and when the rash appears the patient's fever may spike up to 104. So that is what I told you in the previous MCQ, that in measles you will not only have fever but the fever will also overlap with the rash, while in roseola the fever completely goes away and suddenly the rash appears. So it's called as a rainbow after the storm. Okay, that is how roseola is described as. Okay, now syphilis. Now syphilis is a very very important topic. One of the one of the MCQs, that we discussed now, one of the options was congenital syphilis. So you need to know everything about congenital syphilis. Now, congenital syphilis can be divided into two. One is early congenital syphilis and the other is late congenital syphilis. So, early congenital syphilis will be less than 2 years after you have after the birth of the child. Okay, so early congenital is up to 2 years, and beyond that there is late congenital syphilis. Now, please remember, early congenital syphilis, why does it happen? It happens because of the transplacental transfer of the treponema pallidum from the mother to the child. So there is direct hematogenous dissemination of the treponema pallidum, correct? So early congenital syphilis in a child is equal to secondary syphilis occurring in an adult, correct? Now, the classical manifestations of secondary syphilis in an adult are almost similar to the manifestations that you see in a child. So of course there will be a rash, there will be mucus patches, there will be condyloma lata, right? But in addition, what you need to remember, in secondary syphilis in an adult, you never see any vesicular lesions, you never see any bullous lesions. But in early congenital syphilis, you do see vesicular lesions, bullous lesions, and that has been called as syphilitic pemphigus. Please remember, very important MCQ, the most common and the earliest sign of early congenital syphilis is snuffles. Snuffles means rhinitis. Okay. So it forms the Buono's triad. So please remember the Buono's triad. The Buono's triad includes snuffles, palmoplantar bullae and splenomegaly. And then there is a Marfan's diagnostic pentad. The Marfan's diagnostic pentad includes the Buono's triad of snuffles, palmoplantar bullae, splenomegaly. Along with that, there is cutaneous syphilids and pseudoparalysis. So the cutaneous lesions of a patient having early congenital syphilis, you will see a vesiculobullous rash which has been described as syphilitic pemphigus. You will see rhinitis, you will see mucus patches, you will see condyloma lata, you will see nail changes like paronychia, claw nails, shedding of nails can be seen. Alopecia can be seen where there will be only brittle and sparse hair present. Mucosal lesions can be seen in the form of rhinitis, breathing and suckling difficulties, pharyngitis, obstruction to the larynx can also occur, and that can result in a characteristic hoarse cry which is called as syphilitic aphonia and cough. It can also cause osteochondritis of the long bones. There is pseudoparalysis of parrot. Okay, because of the pain, the child does not move. Okay, so that is called as the pseudoparalysis of parrot. And syphilitic dactylitis can be seen. Okay, on X-ray examination, you will see the Wimberger sign positive. So remember, Wimberger sign on an X-ray is seen in early congenital syphilis. Okay, remember Wimberger sign. It is basically an erosion on the tibia. Okay, then we go to late congenital syphilis. So basically what is late congenital syphilis? It is basically the delayed consequences of localized inflammatory processes established at the sites of treponemial infection during early stage of the disease. So these manifestations you will see beyond the second year of life, and they are going to correspond to the tertiary stage of acquired syphilis. So in this stage, you are going to see the Hutcheson's triad. So what is the Hutcheson's triad? The Hutcheson's triad is interstitial keratitis, eighth nerve deafness with Hutcheson's teeth. What are Hutcheson's teeth? They are upper central incisors which have a notch at the biting edge. Okay, and there are mulberry molars. Okay, so that is the Hutcheson's triad. So remember, in late congenital syphilis, you have the Hutcheson's triad. And then you have other manifestations which are syphilitic stigmata. So if you go from up to down, you have the frontal bossing, you have hot cross bun deformity, you have an Olympian brow, high cranium or a tower skull. Then you go to the nose, you have a saddle nose deformity. Go to the maxilla, you have a short maxilla, high palatal arch. Then you go to the mandible, you have a bulldog jaw. Then in the eyes you have interstitial keratitis. Then in the perioral region you have perioral rugards. Inside the mouth you have Hutcheson's notch incisors. You have mulberry molars. Then you go to the clavicle. You have the Higumenaki sign, which is thickening of the medial angle of the clavicle. In the throat there is hoarseness of voice. And then go down to the scapula. You have a scaphoid shaped scapula, and down you have the Clutton's joints, and you will have the saber tibia. Okay, so these are the manifestations which you will see as syphilitic stigmata. Okay, so remember everything from up to down. It will be easy for you to remember. I will just revise once more. Start with the parietal bone. So there is hot cross bun deformity, there is frontal bossing, there is Olympian brow, there is high cranium or a tower skull. Then go to the eyes, there is interstitial keratitis. On the nose, there is a saddle nose. In the ears, there is sensory neural hearing loss. In the maxilla, it is a short maxilla. There is a high palatal arch. On the mandible, it's a prominent mandible. It's called as a bulldog jaw. There are perioral rugards. Inside the mouth, there is Hutcheson's teeth, mulberry molars. Then in the throat, you have hoarseness of voice. In the clavicle, you have the Higumenaki sign, which is thickening of the medial end of the clavicle. Then you have Clutton's joints, and you have the saber tibia, which is the anterior bending of the tibia. Saber literally means a sword. Okay, so these are the syphilitic stigmata. Now, let's go to the next question. You have a 42-year-old woman who presents with brown papules located around the nail of the thumb. Which of the following treatments is most likely to cause hypopigmentation? The question is, which of these is going to cause hypopigmentation? Liquid nitrogen, low voltage high fraction, keratolytic moisturizer, or snip excision? Which of these will cause hypopigmentation? Jyoti, Daud, Vipesh, Aishwarya, Siva, anyone? See, they have see, first of all, what is the diagnosis? The diagnosis is very straightforward. It's a very classical hyperkeratotic, slightly verrucous surfaced papule, which is kind of present in the periungual region. Okay, so the clinical diagnosis here, it's that it is a wart and it is a periungual wart. So when you have to treat a periungual wart, you have multiple modalities that you can use. You can either use a keratolytic agent, you can either do an electrocautery, which is low voltage, high fraction, or you can do a cryotherapy with liquid nitrogen, or you can excise it. Okay, so they have enumerated all the four options. Now they have specifically asked you which of the following treatments is going to cause hypopigmentation. Now, hypopigmentation will happen only with liquid nitrogen. Okay, hypopigmentation is not a side effect of 2, 3, or 4. The answer is 1 here. Okay, why? Because liquid nitrogen is going to be sometimes damaging to the melanocytes, as a result of which that area can become hypopigmented. Okay, liquid nitrogen cryotherapy may be painful. There is chance of scarring of the matrix with aggressive freezing. Pain and erythema may be reduced by a single application of a very potent steroid. Okay, so what do we use in cryotherapy? The cryogen that is most commonly used is liquid nitrogen. The temperature, this again is a very important MCQ. The temperature at which the liquid nitrogen is used is 196 degrees Celsius. And basically the effect on the wart clearance is because of the destruction of the HPV infected keratinocytes, or by inducing local inflammation that triggers an effective cell mediated response. Okay, so adverse effects include hypopigmentation more commonly than hyperpigmentation. There can be tendon or nerve damage when therapy is too aggressive, and recurrence can happen along the treated wart. Okay, so it will be kind of an annular recurrence, which is called as a donut wart. Okay, now this is the last question that we'll be able to take up. So the question is, a 7-year-old female presents with fever, sore throat, facial rash. Physical examination reveals an erythematous pharynx without exudates, couple of red painful patches on the child's cheek that the mother notes has been expanding. What is the appropriate therapy? So look at the picture, make a diagnosis and tell me what you will use. Yes, so Vipesh, Aishwarya, both of you are right. The correct answer is topical antibiotics. But because what we can see here is that this is basically a lesion which is topped with honey colored crusts, and underlying it there are superficial erosions. Right, so this is very classically impetigo contagiosa, which is caused by staphylococci and streptococci, more common in the tropical areas. Starts off as a very transient vesicle which develops a pustule and then forms a erosion, and typically it gets covered with honey colored crusts. Okay, so since it's a bacterial infection, the treatment will be with topical antibiotics. Considering the fact that it's quite localized, you can afford to use a topical antibiotic. If they are extensive lesions, if there is associated systemic symptom like fever, if there is associated lymphadenopathy, then in that case definitely you would opt to give a systemic antibiotic. Okay, topical steroid, salicylic acid, isotretinoin, they do not have any role in the treatment of impetigo. Okay, so there are two types of impetigo. One is the one which is bullous impetigo, mainly caused by staphylococci, and then you have the non-bullous impetigo, which is impetigo contagiosa, which we saw in the picture. Okay, the treatment is of course topical and systemic antibiotics. Okay, so that's the time we have today. Thank you very much for attending the lecture. Please do attend the Unacademy All India mock test. Okay, so with that I take your leave, and please be there on Unacademy. Please subscribe to Unacademy as well as follow me on Unacademy. On 19th and 20th, we begin with our ultra fast revision for NEET PG 2022. So I will be taking the revision between 9 a.m. to 11 a.m. 2 hours on Saturday and Sundays. Okay, so please be there. Thank you very much for attending. See you. Bye.